All right, the final lecture of this semester is late life depression and nursing care, and we'll also talk about a couple of other mental health issues that occur later in life. So if you go back and think about the Erickson stages that we talked about early in the semester, you want to think about the stage for older adults was ego integrity versus despair. And in that stage, older adults are adjusting to a huge amount of changes in their life, decreasing physical strength and health, retirement and reduced income, death of a spouse, establishing an affiliation with one's own age group where they may not have done that much in the past because they've been very oriented with their children and their grandchildren, meeting other civic and social obligations, establishing satisfactory living arrangements, and finding new meaning in life. Depression is prevalent in community dwelling older adults from 3 to 5%, and about 13% of those have clinically significant symptoms. But those who are in long-term care environments and even in independent living environments will have much higher rates. Traditional long-term care environments can have rates as high as 35%. Often depression is not recognized because it's not a primary focus of physicians, or it's so very common in long-term care that the nursing staff and the physicians just overlook it. It also is highly recurrent. It has recurrent episodes in more than 50% of the persons that it impacts. And the highest risk of suicide is in persons of 65 years of age and older, especially in males. Because of the high risk of occurrence, there's more physical disability, more impairment of role, and that increased risk of suicide. We also often overlook alcoholism, anxiety and panic attacks due to recent losses. I could tell you that many times people overlook alcoholism, and it's something that you really need to ask older adults, just like you would ask younger adults. How many drinks a day? About what time do you start drinking? And you know that we triple whatever they say. So if they say they have 1 beer a night, then we put down 3 at least. So it's important to really assess that for a couple of reasons. We want to make sure that we can minimize symptoms of withdrawal if those should occur. But we also kind of want to anticipate those because they could make it could cause complications in the care of that individual. Risk factors for depression. Now, while males have a much higher rate of suicide in this age group, females are much higher rates of depression in this group. So female is a risk factor if they have lower socioeconomic status, those who've been separated, divorced, or widowed, and those with a family history of suicide, mood disorders, alcoholism, or trauma. You don't always know about the trauma, and you might not know about the alcoholism, so you need to explore some of those issues with family if they will tell you, and the patient. So the late life depression can be caused by a lot of different things. We've talked about quite a few of these, but one of the things that I think is important is losses. And individuals who are older will begin to lose friends, family members, spouses, roles. They have a ton of losses, and every single one of those losses, whether it's a job or a volunteer organization, they go through this grieving process. And that is really difficult for a lot of individuals. So don't underestimate the losses that they might be experiencing. Also, individuals who are older may lack support systems. They may not know how to handle stressors well. They may have medical conditions or drug toxicities or substance abuse problems. They could have biomedical imbalances like serotonin deficits or vascular changes from strokes or other issues that is causing a problem with neurotransmission. And then when you start adding the comorbidities like smoking or diabetes and hypertension and age-related changes in the brain, an individual's much more predisposed to having late life depression. So it is a challenge sometimes to assess depression in older adults. We often have more expression of somatic complaints or physical problems, headache, stomach ache, fatigue. Um, People, especially in this age group, will minimize psychological problems. It's considered a weakness to have mental health issues, whereas beginning about in my generation, people feel much more apt to seek out psychological assistance and counseling and help. Also, make sure that we rule out any medical comorbidity and try to determine if there's any physical cause for pain or other symptoms so that we can make sure we're treating those and not ignoring something that might be physical. Then we could have the presence of other psychiatric comorbidities or rationalization by patient, family, or caregivers. There's also a syndrome called pseudodementia where adults exhibit symptoms that are very consistent with dementia but are actually caused by mood, loss of memory, and vagueness and slowing of movement. Pseudodementia can be really difficult to diagnose and treat as well, and so that's another good time that we go and see a neurologist that is trained very specifically in detecting dementia and pseudodementia. We've covered the geriatric depression scale previously. Remember that we score this yes or no, and that 0 to 4 is normal, and then the scale goes up as far as depression, as the higher, closer to 14, indicates a more severe depression. Warning signs of suicide: anyone who is talking about wanting to die or kill themselves, they're looking for a way. If they specify how they're going to do it, it's a higher risk for suicide. If they talk about feeling hopeless or trapped or powerless, that can be a sign. Individuals who are sleeping too little or too much, or withdrawing or feeling isolated. So we want to reduce the risk of suicide or self-neglect, and so assessing the risk is important, and then clarifying that management plan and consider admissions for any high-risk patients. The hard part is that admissions are sometimes very hard to come by, and the person may have to wait a couple weeks before we can get them admitted, and that might be too late. We definitely want to try to help them to feel better, so we're looking for remission of the depressive symptoms, and educate the patient about depression and its treatment, help that patient achieve the best possible function that they can, and get the referrals to appropriate agencies and individuals so we can pull a support system in for that individual, review medications and make sure we get rid of any that aren't necessary, and emphasize the importance of adhering to medication therapy. We want to continue treatment for at least 12 months after recovery and then give some maintenance or preventative treatment. We can use antidepressants with older adults, but we do want to make sure that there is a true benefit for each. So you want to think about how well tolerated a medicine would be if it's covered by their insurance, and then what some of the risks are. Mirtazapine is a good medication. It works pretty well. Patients can become a little sleepy on it, and they can gain a lot of weight. Gaining weight can be beneficial, but it also might not be. So that's another one of those that people won't understand about that medication. So they'll start taking it and seriously want to eat everything in the house, and then they'll start to notice that weight gain, and it could be really distressing for some individuals. So, as we look at those antidepressant agents, make sure that you also are familiar with the possible adverse effects so that you can anticipate those if they should occur. So, review those with individuals, especially like orthostatic hypotension. Help them realize that they need to sit up slowly from bed and then move to a standing position slowly as well, and that they might feel some dizziness in there. You won't be tested on the side effects or possible adverse effects of these. It's just another reminder to review those carefully. Well, slide is out of place, so that was it for the lecture. Um, I hope that you had a good semester this semester.